Hi everyone, my name is Mary Easterling, and this is my capstone presentation based on my capstone paper for spring 2025. This presentation will be into two different sections. The first section will focus on my experiences with one client in the entire therapeutic process, and the second section will focus on different issues I faced with three different clients. This first section will include my experience throughout the engagement, assessment, intervention, and evaluation phases with this client. And I will be describing the different details of the therapeutic process that I experienced with this client in my field placement. The first phase that I experienced with this client was the engagement phase. Throughout my time engaging with this client, I was able to apply my knowledge of social work practice that I already had. I was also able to grow that knowledge at the same time. The knowledge of social work practice that I already had was able to provide a foundation which I built upon while progressing through treatment with this client. When first interacting with this client, I knew it was important for me to create a calming and inviting presence in order to promote the building of rapport with this client. I also knew that I needed to allow this client the space to voice his own experiences in a supportive setting. So the next stage that was entered was the assessment stage. These are just some demographics about this client. He's a 65-year-old male, uses he, him pronouns. He is heterosexual, divorced, he has no children. He is currently unemployed, and he identifies as a Christian. This individual was referred to the agency I was placed at due to possible suicidal ideation. Upon arriving to his home, the client disclosed that he was currently using methamphetamines. He stated that he was not suicidal, but he had been feeling depressed for a very long time. It was decided to create a safety plan with him, just in the case that it would be useful to him or he would need to use it. This is when he disclosed that he had been experiencing auditory and visual hallucinations due to the methamphetamine use. After discussing treatment options and completing his safety plan, he decided he wanted to stay home while coming down from his high and asked to be followed up with the next day. The following day, he was no longer high and was much more relaxed. He apologized for his behavior and stated that he had not done drugs for many months before that. He also stated that his friend had introduced him to the methamphetamines, and she had been there the day before doing the methamphetamines with him. He also shared that he had wanted to use substances as a way to escape his depression, but once he was using the substances, he felt that they had the opposite effect on him and made his depression worse. He expressed wanting to begin therapy services at the agency I was placed at in order to treat the depression he had experienced for years. So, I feel there are two presenting problems for this case. The first being the methamphetamine use, but the largest one being his depression that he has experienced for a long time. The methamphetamine use has been going on for about 2 years since he met the friend of his. He states only doing it sporadically. He has stopped being friends with this individual since and has reported no methamphetamine use after this first interaction my agency had with him. The other presenting problem for him is his depression. He states that he has felt depressed for a very long time, especially since the passing of his mother in 2018, as he is still grieving her very deeply. This individual has never experienced psychiatric treatment despite his persistent mental health issues for most of his life. He has also shared that this was due to a very large and common social stigma around mental health, especially at the time of his upbringing. This stigma was very strong in society as well as within his own family. He has many strengths, including that he wants to better himself, and he also has a supportive neighborhood community that he lives in. His neighbors are very supportive of him and provide him a lot of comfort and support through many different phases of his life that he's experienced. Upon his intake, his assigned clinician used different agency assessments to form a diagnosis. The two largest ones that are used at this agency are the PHQ-9 assessment and the DLA-20 assessment. They were very useful in this case. This is the problem list that was developed for this individual. This problem list has the problems as well as the diagnostic criteria that was met in order to form his diagnosis. He has high blood pressure, former and current substance use, previous homelessness, unemployment. He's experienced death of a loved one, and he's been divorced. So his diagnosis that he received was major depressive disorder, a severe recurrent episode, and the diagnostic code is F33.2. And of the criteria, this is what was felt by him. So he experienced depressed mood, low interest in activity, insomnia, loss of energy, and feelings of worthlessness. The symptoms do cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. This episode is not attributable to the physiological effects of a substance or another medical condition. And I just added in, though substance use was identified at time of meeting, the client has experienced these symptoms while not using the substances and has also experienced these symptoms through much of his life long before he began his substance use. At least one major depressive episode is not better explained by schizoaffective disorder and is not superimposed on schizophrenia form disorder, delusional disorder, or other specified and unspecified schizophrenia spectrum and other psychotic disorders. And last, there has never been a manic episode or a hypomanic episode. So the next stage that was entered was the intervention phase. Cognitive behavioral therapy, case management, and psychoeducation were the most influential interventions in this case. After developing his treatment plan, SMART goals were used to help him understand how he would meet his treatment goals of improving his self-esteem and developing healthy coping skills. The implementation of these interventions was smooth, and the client was very committed to working on himself. Throughout sessions, the client discussed a variety of topics, including his troublesome childhood, his hard career, past relationship trauma, and grief that he experiences daily. After about 3 sessions, the client opened up about his grief experience pertaining to his mother. He described the loss of her as the worst heartbreak he had ever felt. It was discussed that he found her loss hard due to just how close he was to her. This client was encouraged to keep 2 journals, one for his coping skills involving his feelings, emotions, and thoughts in the moment of an incident, and another journal was used to document times and things he would otherwise call or talk to his mother about. In order to keep the balance in this therapeutic relationship, both parties remained open throughout treatment. If the client was not on board with an intervention, it was encouraged for him to express this. If the therapist did not see positive change from the client in specific areas or regarding specific goals, that was expressed as well. This was able to keep the client engaged throughout the process while also making him feel that he was involved in his own treatment. So the next phase was the evaluation phase. Consistent assessments were used throughout the treatment process to track the client's progress. These assessments included the PHQ-9 assessment and the DLA-20 assessment. The PHQ-9 assessment was used to track his depressive factors and symptoms, while the DLA-20 assessment was used to track his activities of daily living and how they improved throughout his treatment. This client has strengths, challenges, and needs that were presented throughout the treatment time. His largest strengths were a desire for change, access to resources from local agencies, support from a romantic partner. This partner entered in about a month or so after treatment began, and assessment from the case management team. His challenges and needs were a lack of transportation, a history of substance use, a need for primary care, and a history of homelessness. Throughout his treatment, he was able to receive services to target each of these needs and challenges, as well as exercise his strengths. Each of these needs were strengthened, and he was able to find solutions to assist with them. One that improved the most was his history of substance use. In October, this client used drugs, methamphetamines, and marijuana are his documented drugs of choice a total of 5 times. He had 12 alcoholic drinks throughout the month. In November, the client lowered his drug use to 3 times and his alcohol use to 9 times. In December, the client lowered his drug use again to 2 times and his alcohol use to 8 times. In January, the client remained at 2 times of drug use, but lowered his alcohol use to 5 times. So this is a chart that corresponds with this data. I do also want to add in, as I previously stated before, that although methamphetamines and marijuana are his documented drugs of choice, he has not expressed that he has used methamphetamines since the agency's first interaction with him. So on this chart, when there is substance use, this is him using marijuana. Treatment decisions were heavily persuaded by theoretical frameworks, specifically humanistic theory and systems theory. While humanistic theory was a large basis for treatment goals, systems theory was used heavily through all aspects of treatment with this individual. Due to the multiple systems at play in his life, it was important to target change within each of them in order to see progress with this individual as a whole. Deciding the treatment goals of developing healthy coping skills and improving self-esteem, humanistic theory was the most influential. It included elements of change that needed to take place in order for him to succeed, while also targeting areas that must improve in order for this change to take place. This was similar to systems theory, and using both of them was extremely helpful throughout this process. In conclusion, the case presented above was an incredible challenge for me throughout my field placement. This case required me to apply knowledge I had not had the opportunity to previously apply in the field, and also challenged me to learn more about the therapeutic process, theories, interventions, and other aspects of client care in order to provide this client with a strong foundation for change. While I do feel that the interventions that we used were necessary, the client at the center of this case was able to make outstanding progress with the tools that he was given. So now we are moving into section 2 of my capstone presentation. This section will be focusing on 3 individuals that I assisted throughout my field placement. These are 3 different individuals, and they're different from the first individual that I elaborated on. In addition to engaging in the therapeutic process in my field placement, I was also challenged in assisting individuals facing ethical issues, human diversity and social justice issues, and policy issues. This section will expand on these experiences and the manner in which these topics were engaged with these clients. Unlike the first section, where one individual was the subject, this section will feature details from 3 additional individuals. So the first issue I will be expanding upon is an ethical issue that took place. This dilemma took place with a client who I had been providing services to for multiple months in my field placement. This client has multiple serious mental health diagnoses, and has had instances where it has been difficult to work with her due to them. This specific instance took place after I received a call from another local agency that she receives housing services from. This placement that I was at involved me working for a crisis hotline, and the agency explained that she was expressing suicidal ideation due to one of her friends passing away. I gave her a call to check on her, where she expressed again that she wanted to die. I asked her if she had a plan, to which she abruptly hung up on me. Due to the nature of this situation, I called one of our local mental health police officers and asked that they respond to this call. I later called the police to ask for an update, and they stated that she was doing okay and did not require any further assistance from them. I was relieved to hear this and decided to call to check in on her to see how she was doing. Upon her answering my call, she informed me that she had taken all of her heart medication at once and stated that if I showed up to her house, I would find a dead body. I told her that I would be calling an ambulance to her house to have her medically assisted, to which she refused. She stated that she would be reporting me and would have me fired if an ambulance showed up to her house. Because I was familiar with this client, I knew there was a possibility she had not taken all her medication like she stated, but this posed an ethical issue within me of whether I should call for her to get help. I made the decision to call for her to get help because I did not want to take the chance that she was exaggerating, but her end up needing help. This dilemma was a result of my client's actions and my decision. This dilemma has also affected my relationship with this client because after this incident, she was extremely upset with me and requested her services to be moved to another person, so she did not have to work with me anymore. Although this was upsetting, I know I made the right decision. She actually had taken all of her medication and ended up being taken to the hospital and placed into a 72-hour hold. I feel that there are many similarities between my personal and professional values. I try to keep my personal values aligned with my professional ones because I feel that it helps me maintain a healthier professional persona, as it feels natural to me when I also feel the same personally. This dilemma has caused me to be aware that these things can happen. We often learn of situations and may think, that will never happen to me, but it can. It has also taught me that there may be situations where we must go against what our clients want in order to keep them safe. Supervision was a very useful tool that I used throughout this dilemma. Although I felt I had made the right decision, it was important that I discuss this with my supervisor and verify that I had done the right thing and how to better handle situations such as this one moving forward. My supervisor had been through other events with this client, so he understood why I made this decision. Agency policy was also involved in this dilemma because there are agency policies in place surrounding when to involve medical/law enforcement in cases with clients. We also interact often with the court system, and we must be able to identify when an individual is in need of inpatient treatment. There is a House bill for Mississippi pertaining to when and what involves a mental health commitment. This is similar to what would be the Baker Act in Florida. And using this bill also helped me throughout this process because it kind of gave me a basis of what to look for behavior-wise. The next issue I will be discussing is the human diversity and social justice issue. This issue arose while assisting with a client experiencing racism at the hands of their doctor. I provided services to this client in my field placement last semester and was able to help him navigate through this behavior, as well as receive services from a different agency that would not discriminate against him. The specific doctor that was discriminatory against this client is also known to be discriminatory towards other clients in her practice as well. This is not the first time that this has happened. And this is not the first time that this has happened with an individual that receives services at my agency. This is an issue that affected my client and others relating to their health, potentially putting them in danger. In this case, the issue that can be seen is discrimination relating to race and possibly relating to socioeconomic status as well. This particular client and I do not have any similarities overall. We are both different genders, races, and socioeconomic statuses. While we may not have been similar, I attempted to be as culturally competent as possible in order to make this client feel seen and heard throughout his time in services. I did not experience extreme countertransference in this case, but I will say that it personally affected me how this client was being treated due to it being so unethical, especially from a healthcare professional. The experience that the client has was that he was receiving care from a primary care physician at another local agency that is able to provide services to those who do not have insurance, such as this client. He attended this clinic about 5 times and felt each time that he was not being heard or listened to. He stated that each time he attempted to discuss his symptoms with his doctor, he was shut down and told that it was normal or that he just needed to deal with it. Due to the concerning behavior shared about this doctor, a member of the crisis team I interned with and I accompanied him to his next appointment. The client had been taking medicine to lower his blood pressure for about 2 months and did not feel that it was working. Each time he had an appointment, he shared this and was not listened to. At this appointment, his blood pressure was very high when it was taken. When the doctor stated this, the client stated that he knew, and he had been trying to tell her that the medicine was not working. She stated that she wasn't going to change his medicine and that he could leave if he did not like what she was saying. I would also like to state that my client was a black male and the doctor was a white female. The client decided it would be best to leave and tried to find care somewhere else. The NASW Code of Ethics has a large effect on how I approach all my clients. In this case, how I approached this client and others like him was influenced heavily by our standards of cultural competence. Specifically, this influenced how I proceeded with this client after this appointment was over. While looking for other doctors for this client, I made sure to include him in the process while also keeping an eye out for professionals with more diverse backgrounds that may show the client more respect than he was given at the last agency. Through collaboration, the client and I were able to find a new doctor that he feels more comfortable seeing. He reports feeling seen and heard with this new doctor and has been given new medication that he feels works better. My supervisor at the time was very familiar with this client, as she had worked with him before I started interning at the agency. My supervision session after this incident was when I brought this to her attention. She assisted me in writing a grievance to the agency where the doctor is employed, as well as encouraged me to inform the client of this option as well. I feel that I should have shared this with my supervisor as soon as I was made aware of how this client felt toward the agency, not just after I saw for myself. My work with these populations was advanced because this was an opportunity for me to become more culturally competent and aware in the field. While I attended the appointment with this client with the intent of advocating for him if he needed, he was able to do that for himself no matter how defeated he was at the end. He and I talked about how he felt afterward, and he stated that he was sad for how it ended and how the doctor was acting, but he was proud of himself for advocating for the care he deserves. He and I had also discussed self-advocacy a number of times before, including how important it was for him to advocate for himself, especially in a healthcare setting. I especially discussed this with him so that because he knows himself best and he knows what he needs. The last issue I will be discussing is a policy issue that I experienced with one of my clients. This issue involved one of my clients attempting to obtain food from another local agency's food bank. In this particular situation, my client identified as low income. He had little access to food, but due to not having proper paperwork, he was turned away from the local agency. This sparked action from myself and several others to bring this to the agency's attention and discover ways for this problem to be addressed. The policy in this situation was put into place at this agency, stating that any individual requesting assistance from their food bank must produce documentation with their name, including a photo ID, 2 utility bills, and an income statement. The client that was affected was an individual expressing a great need for food. I referred him to this agency as they are a large partner with the agency I was placed at. Upon referring this individual, he reported back to me that he was turned away due to not having the documentation that he needed. I asked if he had access to these documents, and he stated that since he was living with his mother, none of the utility bills were in his name. And when asked if he was able to bring, he asked if he could bring those bills as proof, and the agency said no. I asked if he would be able to bring his mother to the food bank, and he stated that he would not be able to, as his mother is extremely sick and elderly and is not able to leave the house much. In order to be more accommodating to individuals in need, the policy described above could be changed. One way that this policy could be changed is by not allowing as much documentation in order to receive services. So they could not require the individuals to bring as much documentation in order to receive the services. If the agency only required 1 or 2 of these documents to be produced, my client could have received services by producing his ID and an income statement, but because he was not able to produce a utility bill in his name, he was turned away. I attended a local meeting to meet with the representatives of this agency. I explained to them the situation and was supported in my argument with the information from other agencies that were in attendance that had similar experiences. We were able to discuss these matters with these representatives and provide them some alternative structures to consider for their agency. One of these structures that I suggested was to have a minimum amount of food for each individual that visited the food bank. If the individual produced the correct paperwork, then they would be able to get food based on what their paperwork entailed when it came to their income statement. If the individual was not able to produce the needed paperwork, they would still be able to receive the minimum amount of food in order to hold them over until they were able to produce the paperwork needed. I also presented the idea of requiring less paperwork or providing a paperwork list and only requiring 2 or 3 of the items on the list. Expressing my concerns with the agency representatives was able to give them insight that they might not have regarding outside agencies. It also gave them the opportunity to know how their resources are being used and marketed towards those in the community. The representatives that were part of this discussion stated that they had heard this was happening before, but did not know the extent to which it was affecting community members. In order to evaluate the effectiveness of my policy practice, I would keep track of the number of individuals I referred to this agency and how their services played out. I would be able to keep track of the number of individuals that were able to receive services, as well as the number of individuals that were still not able to receive services. I would also be able to compare the newer services with older services by assessing clients who received these services in the past and have them compare the past services to the newer services. If the agency puts new policies into practice, that could affect the service quality that is provided to them in order for them to assist more individuals. In conclusion, the issues faced by these clients were able to provide me an opportunity to assist them in navigating the aftermath of these issues. The issues that were experienced by these clients exercised many skills that I have learned throughout the program, as well as other skills that I had less knowledge on. These issues were also proof that there is still work needed in our system and that there are still individuals who would benefit from continued social change.